traigo desde la Sociedad Argentina de Nefrología el reconocimiento y las felicitaciones de la comisión directiva a la Sociedad de Nefrología, a Hipertensión y Medio Interno de Córdoba, al comité organizador de este evento. Han hecho un trabajo fantástico por la calidad de los contenidos, la excelencia de los speakers y sobre todo por la precisión de esta organización que nos ha introducido a lo que es la medicina de precisión. Y en ese sentido, el conferencista que voy a presentar tiene mucho que ver en esto, porque él se dedica en su actividad profesional justamente a la medicina de precisión y ha sido de alguna manera uno de los inspiradores de que la Sociedad de Nefrología de Córdoba elija este tema que para muchos de nosotros es extremadamente novedoso, pero que al mismo tiempo vemos la importancia y el valor que tiene. El doctor Ali Garabí, que va a iniciar la siguiente conferencia, ya fue presentado, pero vale la pena, digamos, repetirlo por si alguno no estaba. Es profesor de la Universidad de Columbia, del Centro Médico Columbia, y él trabaja en el departamento de medicina. Y él se dedica en su actividad, digamos, profesional a esto que les estoy diciendo, que trabaja centrado un poco en esto de la medicina de precisión. Y para esta conferencia, que sería la conferencia del cierre, se eligió justamente el tema de la nefrología de precisión, enfocado un poco en la secuenciación clínica para el diagnóstico y la terapia de la enfermedad renal crónica. Así que a posteriori de la charla del doctor Garabí, van a hacer el cierre los anfitriones y posterior tenemos un cóctel finalizado esto que no deberá llevar más de 45 o 50 minutos. Así que doctor Garabí, por favor. Perdón, no me...
Okay, okay, now you can hear me. Okay, very good. So, what I'm going to talk to you about is, the theme I was invited to talk about was about precision medicine for kidney diseases. And so I wanted to just really talk about a little bit about what we mean by precision medicine. Because as doctors, I don't think any of us think we are practicing imprecise medicine. Do any of you think about practicing imprecise medicine when you get up in the morning? So that's the reality is that we all try to provide the best care for our patients given the amount of information and knowledge that we have to bring to bear to answer a number of questions that patients have of us. And these are the questions that patients come to us, all of us, when we see a patient. They want to know and ask us, what is this disease? Why do I have this disease? What will happen to me? And what are the treatment options that are available, right? So this is what we really try to address. The difference is that nowadays we have a new set of tools that are available to us to be able to answer these questions a little bit better. The questions that we're dealing with kidney disease oftentimes, for example, is that in many cases patients present very late in the course of disease. And in those cases, the clinical data that we have and the kidney biopsy is not informative. So somewhere around 15% of patients with end-stage kidney failure in the United States are assigned a diagnosis of CKD of unknown origin. So we don't know how to treat these patients, we don't know what will happen to them after renal transplantation, who will donate the kidney to them. And so that's among the many questions that are posed to clinicians. That's an example of where we can do better in terms of providing at least a diagnosis as a starting point. To answer the first question, what is this disease? Well, because of changes in technology that's come about, particularly genome sequencing technology, an experience that a physician may have increasingly is the following. A patient may come to them and say, doctor, should we perform genome sequencing to answer these questions? And many people in the United States have access to direct-to-consumer care and direct-to-consumer genetic testing and may already come with some genome sequence data already performed, and they want you in the clinic to interpret the genome sequence data. So how many of you have ordered genetic testing for your patients in your practice? Not that many? Yes, a few people. how many of you have had any kind of genetic testing done for yourselves? In the United States, there are companies that offer some kind of, they can tell you about your ancestry, for example. Do they have these companies in Argentina? Okay, so somewhere around 1% of the population in the United States has had some form of genetic testing done. I wouldn't say it's a clinical grade genetic testing, but it had some sort of genetic analysis done on their DNA. And these commercial companies, promise to tell you, for example, about your ancestry, and there's now about 18 clinical tests that are available in direct-to-consumer testing in the United States, and I assume that this will only become more prevalent all over the world. Well, some of these questions came about as I've studied, two major diseases in my career, and those have been IgA nephropathy, you heard about, and then congenital kidney defects. And as we were trying to study these and find new genes and new pathways that are involved, we realized that we are making new diagnoses that we can bring back to patients. And so that completely changed the way I'm doing research, because before I would tell my patients, please give me a tube of blood for research, and we'll try to find things that may matter to you, and maybe it's not going to matter to you directly or immediately. It may matter to you, 20 years from now, and frankly, it may not matter to you at all, and honestly, you may never hear from me ever again after you give this tube of blood. About 5 years ago, we completely changed the consent form for our research projects. Now, in our consent forms, we say, there is a chance that we might find something during the course of this research that may matter directly to your health, and that we would like the opportunity to return these results to you. So that's completely changed also the way not only we practice medicine, but also the way we do research. So let me tell you more about this. So the Human Genome Project wound up developing the first the map of the human genome, and then the complete sequence of the human genome was published in 2001. There are 3 billion nucleotides of 3 billion letters in our genomes, and it took 10 years and $3 billion to be able to sequence this first draft. Subsequently, because of advances of genome sequencing technology, we now can sequence individual genomes now in about 24 to 48 hours, and the cost is about $1,000 to $2,000. And the big challenge now is to be able to interpret the genome and basically to identify this one single typo in these 3 billion letters that explains the clinical presentation in front of you. So just to give you some idea, the human genome has 3 billion letters. War and Peace has 3 million letters. So every time you come to interpret a human genome, it's like reading 1,000 copies of War and Peace to find one typo. So that's the real challenge that we're facing. So let me give you a few cases, real cases that we've encountered that we dealt with to give you an appreciation of what is possible. This is a 20-year-old male who was admitted to the hospital after a suicide attempt. His mother contacted me because they had told me about him. He has no formal psychiatric history, but had always had difficulties in learning in school and had dropped out of school before completing his high school degree. And he had been estranged from his family, only reconnected after this suicide attempt. What was interesting about him, and that's the reason she called me, is that he has a history of a solitary kidney that was diagnosed at birth. At the time, a nephrology consultation was sought, and the nephrologist told them, well, no, he'll be fine, he'll get by just fine with one kidney, and that's okay. Well, over the years when these neuropsychiatric issues developed, his mother was often wondering, is there a connection between the neuropsychiatric disease and the kidney malformation, and was told that there isn't. She came to us and said, should we do genome sequencing to see if we can answer these questions, if there's a relationship between these two issues. Here's another case. This is a patient who was referred to us with hypomagnesemia. When we did the workup, it turns out that she has kidney cysts. And then we started asking her about more questions, and she said to me, doctor, I'm just unlucky. Every time I go see a different doctor, they find something new about me. I found out that I have low magnesium in the blood. You tell me I have cysts in my kidneys. I was diagnosed with diabetes. And then when we was part of the history, and we asked her another question. We said, do you have children? And she said, no, I'm really unlucky. I didn't have kids because I have malformations in my uterus and I could never have kids. And so, and she's had a lot of problems dealing with these issues. There was no formal psychiatric history, although she told us that she really struggled to complete college and she was never able to complete college. So these patients have a spectrum of disease called congenital malformations of the kidney and the urinary tract, CACUT. Some of you may have heard this. This is the most common cause of kidney failure in children. 50% of children who have kidney failure have one of these problems, which can be vesical ureteric reflux, duplicated ureters, multicystic dysplastic kidneys, unilateral hypoplasia or dysplasia. 10% of adults with chronic kidney failure and on dialysis in the United States have one of these problems. So these are congenital defects, and so what we do know about congenital defects is that genetic factors are often very important. Well, as clinicians, we know about karyotyping and karyotype testing. We're all familiar with this, right? So we look at the chromosome material under a microscope to identify if there are gains and losses of genome material, right? So that's, you guys are familiar with this, right? And so, for an example of this, this is a normal female karyotype here on the top left. And then on the bottom, you have, here's a pointer. Can you see the pointer right here? Yeah, okay. So this is the normal, oops, so I'm going back, sorry. So this is a normal female karyotype, this is the normal male karyotype. Here on the top left, you see trisomy 21, you have an extra chromosome 21, so that's Down syndrome, right? We're all familiar with this classical presentation. And then Turner syndrome is XO. Here we're missing an X chromosome. This is a phenotypic female, but she's missing an X chromosome. There are all kinds of other issues involved with this. So these are major deletions and duplications of the genome. It turns out that there are smaller deletions and duplications of the genome that we cannot see under the microscope like this. But we can see those with a technology called microarray. Okay, and so microarray technology. Oops, I'm getting confused. Okay, microarray technology involves essentially a chip which has probes that covers the entire genome, and you can see through the intensity of the hybridization whether there's gain or loss of chromosomal material. So we ordered this test, which is the form of sequencing in a way, because you're looking to see if there's a major deletion and duplication in these two individuals. And so this is a readout that you get. So this is the easiest thing to look at here is the intensity probes. Each dot represents the intensity from a single probe. And you can see there's a drop in the signal around this region on chromosome 17q12. And so this indicates that there's a deletion of 1.2 million bases in these two individuals. And it basically deletes this region, which contains a large number of genes, including one gene called hepatocyte nuclear factor 1 beta, HNF1 beta. And this gene we know is really important for kidney development. It's a transcription factor that's really important for kidney development. And so this provided a diagnosis for a syndrome in these individuals. They had the 17q12 deletion syndrome. This is also called the renal cyst and diabetes syndrome. Have any of you encountered this syndrome before? Well, I'm going to bet you that you have encountered this syndrome before in your practice. You've seen this case. Yes, absolutely. So, but maybe you've overlooked it. So, the deletion of HNF1 beta, this transcription factor, results in phenotypes that include kidney malformations, kidney cysts, single kidneys, hypoplastic kidneys. There's also tubulopathy associated with this disease, resulting in hypomagnesemia. These patients also have abnormalities in uric acid handling and develop hyperuricemia and gout, have liver function test abnormalities. In women, you have genital tract malformations resulting in uterine malformations and inability to conceive. And more important, also importantly, the deletion of this locus is associated with cognitive defect, neurodevelopmental defect, and there's a 2 to 3-fold increased risk for autism spectrum disorder and cognitive impairment. So what you can see here is this single genetic diagnosis essentially explained the clinical manifestations that we saw in the young man who had the kidney malformations and then neurocognitive defects. So those two can be linked completely via this genetic mutation. The 64-year-old woman also had this syndrome. Her presentation was even more classical because she had the renal cysts, she had the diabetes, which developed later on in age. So it's interesting to know the loss of this transcription factor results in pancreatic insufficiency. The kidney malformations are apparent around, at birth, at a very young age. The the diabetes tends to occur around age 25 or 30, and oftentimes people don't put the two together. So, and sometimes even these patients get misdiagnosed as having diabetic nephropathy before a ultrasound is needed, the cysts are identified. So we've looked at the prevalence of this syndrome in about 1,500 cases of adults with chronic kidney disease and diabetes. And we found this deletion in 1 in 250 patients with CKD and diabetes. So how many of you have treated at least 250 patients with CKD and diabetes? Just a couple of people. Okay, so I would say for those of you who treated a bunch of these patients, of those phenotypes, statistically it's likely that you've encountered this particular conditions but didn't think about it, but didn't pick it up. So it turns out that this particular syndrome is not unique. This is not the only thing that we found. So we've done large-scale studies in patients with, starting with patients with chronic kidney disease, children with chronic kidney disease, and the last study we just published had about 3,000 cases and about 21,000 controls. So here you're looking at the genome by chromosome, and each red signal represents a deletion, and in blue you have a duplication of these regions. Each one of these is diagnostic of a different syndrome. So there are 40 different syndromes that we identified in 8% of these individuals. And so this told us that there's a tremendous heterogeneity, tons of different genetic disorders just detectable by these deletion and duplication analysis in children with chronic kidney disease. What was really interesting also is that when we compared the genetic diagnosis that we made through microarray testing and compared it to the clinical diagnosis, we saw that there was a number of cases of discrepancies. For example, in a number of patients who had this renal cyst and diabetes syndrome, they carry the diagnosis of glomerulopathy because they have hypoplastic kidneys that can develop a secondary focal sclerosis and proteinuria, and they get misassigned to having FSGS. And as you know, in children, we do not perform kidney biopsies very often. So these individuals may undergo immunosuppressive therapy with no avail because they have a structural defect. This is basically the case that Dr. Fogo presented earlier in the patient by transplantation and was initially diagnosed with having a focal sclerosis, but on a review of the native kidney biopsy, she had some sort of obstructive uropathy, she had a congenital defect. So there's a real opportunity for individualizing care because each one of these syndromes comes with a different set of manifestations and complications. I told you about the 17q deletion syndrome. This is another syndrome very commonly found, 17p11.2 microdeletion, which causes not just kidney malformations, but also cardiac malformations, intellectual disability, obesity, epilepsy, and skeletal defects. The DGeorge syndrome that we hear about in medical school that is classically associated with cardiac malformation causes kidney malformations in about 1/3 of cases. It's also associated with intellectual disability, immune deficiency, and everything else. What we realized is that in fact every single one of these 40 genomic disorders that we identified have already been described in the setting of neuropsychiatric disease in a lot of studies of autism, schizophrenia, and neurodevelopmental disorders. So these are the same set of disorders that cause a multi-system problem, but depending on where the patient and which specialist sees the patient, they get labeled as having CKD with hypoplastic kidneys, or they get labeled as having autism and schizophrenia, or they get labeled as having cardiac malformations. But without the genetic diagnosis, you cannot put the whole picture together and you can't come up with the name of the syndrome. So I think we thought that was really important. So how about in the adult population? Most of you probably here are adult nephrologists, so does that matter to your practice in adult nephrology? So we just looked at about 3,300 patients with chronic kidney disease of all etiology. And 1.5% of these patients had one of these genomic syndromic problems. And so there are multiple different disorders that were identified. So these are patients that you actually encounter in your in your practice. And as I already mentioned, 1 in 250 cases of CKD with diabetes have the 17q12 deletion syndrome. Well, there's a lot of literature as well looking at neurocognitive impairment in patients with CKD and particularly in patients with dialysis, depression, cognitive impairment, and so forth. well, we started looking at a number of mini-mental status scores in these patients who had one of these genomic diagnoses, one of these syndromes, and those that didn't. And what you can see here is that you can see a significant difference in the mini-mental status score, which was much lower in those who had one of these genomic disorders. In addition, when you look at education level as a surrogate for cognitive development, well, those patients who had one of these genomic disorders were much more likely to just only complete high school. They couldn't complete, they never really went on to university. Whereas the ones who didn't have it were, had the population level prevalence of university education. So this has an impact and can explain some of the core comorbidities that we misattribute to CKD in this subset of population. So I just told you just about one type of genomic analysis, which is looking at one type of mutation, deletions and duplications. But most of the mutations in the genome are single nucleotide or single letter changes. And these types of changes you can detect by a technique called exome sequencing. So there are 3 billion letters in our genome. Of that, there are 20,000 genes in the genome that are encoded within this. And so that's only about 1 to 1.5% of the entire genome, and that's in there. And as you know, genes are organized into coding segments. And basically, when we sequence, we want to sequence the coding segments of the genome. That's called the exome. So when you think about the genome as a whole, orange, the exome is sort of the tastiest portion of the genome, the small portion that we can really easily interpret in the genome. So we've used exome sequencing to identify new genes for kidney disease, looking at families that had no clear diagnosis. So in the past, we've identified a number of genes that are associated with kidney malformations. So this one gene called DSTYK causes congenital kidney defects. And then just a couple of years ago, we identified another gene called REB1L, which is associated with kidney disease. So I see something here on the screen. Okay, good. So when this technology of exome sequencing came into use, people immediately saw that there is a good use for clinical diagnosis. So these are papers that were published pretty recently, first looking mostly at children who had neurodevelopmental disorders. So on the top left, you see a paper in the New England Journal. This was the first paper looking at the diagnostic utility. In 250 individuals, about 20% of them were adults. These mostly had neurodevelopmental disorders, and the diagnostic rate was about 25%. A subsequent study, JAMA, in 2014, this in a larger cohort of patients. And then the other area where sequencing has become really prevalent is in cancer. And so here's a paper on the top right looking at 500 cases of adults with metastatic cancer. And there you find that 12% of cases have a mutation in their genome that predisposes to cancer. So, and in fact now in the oncology world, there is no clinical trial that's going to be sponsored by the National Cancer Institute without genome sequencing being as part of the pipeline and as part of the protocol. So we performed a small pilot project to look at the diagnostic utility of exome sequencing, looking at 92 patients, and I'll tell you a little bit more about it. So basically, just again to summarize, if we have the whole genome, about 1 or 2% of it is non-coding, and there are 20,000 genes in it. If we reduce the area of that we're going to look at, which is just looking at the coding portion of the genome, that's called the exome, and that's about 2% of the genome. Of all the coding portion of the genome, only 4,000 genes we know out of the 20,000 genes are associated with any kind of clinical disorder. And so this is sometimes called the Mendelian. So in other words, those that are causing Mendelian disorder. And then from there, we wind up doing a quick annotation, or actually not so quick, it took about a year, an annotation of these 4,000 genes, and we realized there are 625 of them that are associated with some form of nephropathy, and those we can call the nephron, essentially. So when we went to do the pilot project of 92 patients, we took patients who had early onset CKD, patients with familial CKD, and patients with CKD of unknown origin. And we wound up making a diagnosis in 22 of these 92 patients. So we had a 24% diagnostic rate. This included 10 individuals in whom we found a diagnosis with CKD of unknown origin, of unknown etiology, in whom we made a diagnosis. And there were 13 distinct genetic disorders that we identified among these 22 cases. So again, a lot of heterogeneity. From there, we said, okay, well, we need to do a little bit better and look to see if there is, this holds across a larger cohort. And we wound up doing a much larger study to try to validate these findings. And this was done by a really talented MD PhD student in our lab, Emily Gruvman. We wind up studying basically 3,300 cases of CKD. About 2,200 cases were seen at our center at Columbia, and then we had another 1,100 cases that we sequenced in collaboration with AstraZeneca Genomics. This was the Aurora cohort. This was a clinical trial looking at the efficacy of statins in patients with end-stage kidney disease. Unfortunately, that trial was negative, but they had DNA samples available so that we could analyze. So we have 3,300 cases, and we did essentially a careful variant annotation to see what is the diagnostic yield. On the right there, you will see the patient characteristics, and I think the most important finding here is that these were mostly adults. 91% of them were adults. They had a multi-ethnic origin, just like we see in patients in New York City. So this was not just a white European population. And we had the full range of clinical diagnoses, going from diabetic nephropathy, hypertensive nephropathy, glomerulopathy. And importantly, 14% of these cases had CKD of unknown cause. So I'll just cut to the chase and tell you about the results. We had the overall diagnostic rate was about 9% in these patients with CKD. Remember, for metastatic cancer, the diagnostic rate is about 12%, so this is pretty similar. And the diagnostic rate really varies across different patient populations. So if there is cystic and congenital defect, the diagnostic rate is somewhere around 24%. And interestingly, for CKD of unknown origin, our diagnostic rate was 17%. You can see this here. And then glomerulopathies have a diagnostic rate of about 8%, and so you go down. Even for hypertensive and diabetic nephropathy, we had a 1.5% to 2% diagnostic rate. So we found a Mendelian genetic disorder in these patients. So the same theme applied as I told you earlier. So this slide we lost this color somehow in the translation, but there were 6 top diagnoses: PKD1 mutations, PKD2 mutations, and then type 4 collagen mutations, and then neuromodulin, which is diagnostic of a tubercular autosomal dominant tuberointerstitial nephropathy. Otherwise, we found the remaining patients had unique genetic disorders. So in total, in these 300 patients in whom we had a genetic diagnosis, there were 66 different genetic disorders that we identified. And so after you went through these top diagnoses, basically you could see a list here that has ends of 1, essentially. So virtually we had all these single individuals who presented with these rare genetic disorders in our clinics, and were essentially most of them went undiagnosed based on clinical evaluation. So let me give you a couple of examples of this to sort of give you a flavor of what's going on. This is a 57-year-old who was diagnosed with kidney disease. He had blood and protein in the urine. The kidney biopsy was reported to us as having focal segmental glomerulosclerosis. He was advised by his nephrologist to start on immunosuppression. He came to us for a second opinion. We reviewed the kidney biopsy, and there were some changes in there which indicated there may be a secondary, FSGS, but we weren't quite sure. So we wound up doing exome sequencing, and it turns out that the patient had a dominant form of Alport syndrome. So essentially, this patient would not benefit really from steroids at all, and so we referred him for a clinical trial that we're doing that was targeting patients with Alport syndrome. So that was really informative for him. This is another example, a 28-year-old female who had kidney failure, had undergone transplantation and was doing really well, but she had a very strong family history of kidney disease, and she wanted to get pregnant again. And so she was concerned about having another child because of a concern for genetic disease. So we wound up doing exome sequencing and realized that she has a recessive form of Alport syndrome. So this basically told us that she could have a child because that all her children will be obligate carriers of the mutation. But when we looked at her family, anybody who was a carrier of the mutation only had 1 copy of the mutation, was perfectly healthy and was doing fine. So we can tell her or reassure her that if she has a child, then the child will remain healthy. So that was really important as well. So it turns out that Alport syndrome and mutations in type 4 collagen genes are the most frequently underdiagnosed case of cause of kidney disease. So here's, as you know, mutations in 3 genes, collagen, A4-3, A4-4, and A4-5 cause autosomal dominant, recessive, or X-linked form of Alport syndrome. When we looked at our patient population, there were 92 patients who had a genetic mutation that was diagnostic of Alport syndrome, but only 40% of them, roughly, had a diagnosis of Alport syndrome or a clinical diagnosis of Alport syndrome of thin basement membrane disease. The rest of them had a clinical diagnosis of CKD of unknown origin, GN not otherwise specified, or focal sclerosis. And this is a tough group of patients that we worry about because they may be exposed to immunosuppression without any any benefit. So I think we should be really careful about this and as we're evaluating our patients. And this is an opportunity for sequencing to be able to inform us about the diagnosis of these patients. Here's another case. A 42-year-old Hispanic man who had chronic kidney disease, had proteinuria, and came to us for evaluation. He also had diabetes, but in these situations, we're trying to biopsy these patients, but the biopsy was not possible in this case because he was morbidly obese. He had a BMI of 72. So we couldn't biopsy him. We told him, you need to lose some weight. That'll be good for your health anyway. That will probably reduce the sort of burden on your kidneys. And you can come back to us, then we'll do the biopsy. And he says, well, doctor, I've been obese all of my life, and I've tried drugs, I've tried diets, and I've been completely unsuccessful. And in fact, I'm considering now bariatric surgery to be able to address this issue. I feel terrible about it. I have no willpower. I can't stop eating. In fact, there are many cases, many times where I have this urge to eat, and I go on these binges and I eat tons of food. So we said, well, we can't do biopsy, we can't do much beyond the usual. So what are we going to do with sequencing? So when we did the sequencing, we realized that he has a mutation in his melanocortin-4 receptor. This is the melanocortin-4 receptor is is really important for transducing the action of leptin. Leptin is a hormone that signals satiety, to our brain. Okay, and so people who have mutations in this MC4R cannot sense satiety, and in fact they have an urge to eat all the time. This is a classic manifestation of this syndrome. So, and it's been shown that bariatric surgery works really well in this population. And so this is an example of one patient who had bariatric surgery, but actually in these patients the bypass procedure works better than the sleeve gastrectomy. So we told them immediately that you should probably have the bypass procedure. In addition, we scanned the literature and there are specific drugs available that target this particular receptor. And so we referred him to our obesity centers. It's a targeted therapy that's available for this particular disease. So these melanocortin-4 receptors account for about 5% of cases of morbid obesity, and they're actually treatable in this nowadays. We also talked to him, and he felt a lot better about this because we told him this is not a character flaw, that he can't stop eating. This is part of the biology of his disease. In addition, he also told us that he has a couple of nephews who exhibit the exact same behavior. So we are now sequencing the other family members to be able to stratify. So this told us this was a little bit outside our panel of classic genes, but because we're really interested in finding the diagnosis, we're able to look outside the kidney diagnosis, the kidney specific genes to be able to make this diagnosis. So when you sequence the exome, I told you there are 625 genes that are known to cause kidney disease, but there are 4,000 other genes that can cause other forms of disease. And so there's a list of 59 genes that have been identified as being actionable by the American College of Medical Genetics. So these include sort of mutations in cancer predisposition genes such as BRCA1 and BRCA2. So if you do an exome and you find mutations in these genes, you're obligated to return these results to the patients. So what we did is we also looked for these mutations in these 59 actionable genes in our patient cohort. So let me tell you about this. This is a 63-year-old who had fibrillary glomerulonephritis. When we did the exome sequencing, we did not identify any mutations that explained her kidney disease. However, we identified a mutation in BRCA2, which indicated predisposition to breast cancer and ovarian cancer. So by the time we got back to the patient, she had undergone mammography and a nodule was found, the biopsy was done, and she had breast cancer. But her treatment pathway changed completely because now we knew about BRCA mutations, and so she wasn't a classical candidate for like a lumpectomy plus radiation or something like this. She actually underwent bilateral mastectomy. And there are now clinical trials showing that there are specific types of classes of drugs, PARP inhibitors, for example, that are much more effective in the treatment of patients who have BRCA1 or BRCA2 mutations. So that also actually provides an opportunity for targeted therapy for her. We also started to sequence the rest of her family. So then we started reviewing sort of what was going on with this patient in terms of the kidney care. Remember, she had fibrillary glomerulonephritis, and we looked at her medications and realized that she's on immunosuppression. So here's a patient who has breast cancer, okay, and who has a genetic predisposition to breast cancer. She had a mastectomy, but she's also predisposed to ovarian cancer, a bunch of other cancers based on her BRCA mutation. We know that immunosuppression increases your risk of cancer in general. So we sort of now have to think about very carefully in the field of immunonephrology, because we use a lot of immunosuppression in a lot of patients. There's going to be 1 to 1.5% of the population that has one of these cancer predisposition mutations. And so this is going to influence the way we're going to approach this. We're going to have to probably tolerate a lower dose of immunosuppression in patients, let's say with transplantation, who have mutations in these genes. So I think that this type of sequencing is going to become routine in the pre-op evaluation of any patient who's going to undergo evaluation for a kidney transplantation, or perhaps patients with glomerulonephritis who also receive immunosuppression. So there are many, many opportunities for targeting, for specializing and sort of developing personalized care for patients with kidney disease through this type of sequencing. However, after you sequence these patients, you realize that there's a lot of variants that you identify that are that you can't interpret, because we all have changes in our genome and we don't have enough information about these changes in our genome. So one of the common outcomes of sequencing is variants of unknown significance. In other words, variants we don't know if they're pathogenic or benign. So that has an opportunity for creating a lot of uncertainty in patients. It's sort of like doing an MRI, finding something, the radiologist says, I found something, it might be a tumor, I'm not sure what to do. And so this is where we are right now in the field. So we can definitely make a certain number of genetic diagnoses that are really highly impactful for clinical care. There's also a number of variants that we found that we don't know quite to interpret, that we're going to have to study. We'll have to figure out, which patients exactly will benefit the most. And based on our study right now, the patients who present with the youngest age and those who have a family history are the ones who have the highest diagnostic yield. So if you really want to go and prioritize who's going to go for genetic testing, for precision diagnostics and therapy, then this is where you need to think about. And then, overall, in terms of the healthcare, we'll have to figure out, who's going to pay for all this diagnostic testing, because you can imagine that this might help a number of people because it's going to streamline their care. But on the other hand, you're also going to find all these variants that may say, well, this person may be predisposed to kidney disease, and then they're going to wind up seeing nephrologists basically because they have a genetic testing to look for cancer or heart disease. We may have a variant of unknown significance, which is in one of the kidney genes, and then there's going to be referrals to nephrologists and other subspecialists. So we'll have to figure out the cost and benefit of this approach. So I'll stop here and maybe take some questions.
Pero si tenemos preguntas, Alejandro.
Excelente conferencia. La población con enfermedad renal crónica tiene una frecuencia mucho mayor que la población general de cáncer. Eso se ha atribuido al tratamiento inmunosupresor, al estado de inmunosupresión de la uremia, etc. Estos genes que están asociados a cáncer, que de alguna forma tienen que ver con la replicación celular, etc., ¿se ha investigado si tienen algún papel en la progresión de la enfermedad renal crónica?
Are you talking about the genes that we found that are you talking about the genes that we found that predispose to cancer?
Yes.
Okay. So these are classic cancer predisposition genes, such as BRCA. So we didn't look to see if there are other genes that, new genes that may predispose to predisposition. What we do know is that some of the kidney, the genetic diseases in the kidney predispose to cancer also. For example, there's recent data showing that PKD1 mutations also have an impact on the cell cycle, and patients with PKD have a higher risk of cancer. So there may be multiple situations where you have the mutation in the gene that causes kidney disease also predisposes to cancer. So that might be one situation. You can have another situation where you have the genetic mutation that causes kidney disease is modified by some other gene that's in the genome, and that particular interaction that results in predisposition to cancer. The third possibility is that you have two different genetic predisposition that's causing this. So in our study, for example, there were among the patients that had a genetic disease diagnosed, 5% had a second genetic disease. So that's been shown in multiple studies, and so that actually also is an opportunity for precision diagnosis. Because in medical school, we are taught that when patients have a whole bunch of different symptoms, we have to find a single unifying diagnosis. So it turns out that in 5% of these cases, people have two different, completely separate disorders, which leads to a complex presentation that you cannot disambiguate so easily. And so it's through the sequencing that you're able to then distinguish that there are two separate problems going on. In this situation, I think the first step is to just find out and identify the subset of patients that have a cancer predisposition mutation that's independent of their kidney problem. Because that impacts the way we're going to treat their kidney disease, in the case of, particularly for the case of immunosuppression. And next, then we'll have to explore if there are other genes that may be predisposing to cancer in the setting of CKD.
Sí, dale.
En nuestra base de datos nacional, que se llama SINTRA, figura más o menos un 20 o un 25% de causas desconocidas de enfermedad renal crónica terminal. En Uruguay, me dice aquí el compañero del otro lado del río, ellos tienen aproximadamente un 30%, que es más o menos lo mismo. En la base de datos americana creo que el orden está alrededor de un 15 a un 20%. Lo que quiero preguntarte, Ali, es si el USRDS estaría evaluando una posibilidad de cambios en la forma que informe el médico la causa de la enfermedad renal en la base del USRDS, en base a estos conocimientos que se van adquiriendo de enfermedades que existen y que antes eran desconocidas.
Yes, absolutely. So this was one of the top sort of categories in which we had a high diagnostic yield, was in CKD of unknown origin. Now, this is important to emphasize that this patient population that we saw had seen nephrologists, okay, and who had had a workup already, and so the nephrologist has said they have CKD of unknown cause. This is not somebody who had an elevated creatinine, an internist saw them and said, I don't know what they have, and I'm going to call them CKD of unknown origin, and I'm going to do a genome sequence. So this is some of these people who were already carefully evaluated, not found to have a classic or a recognizable form of kidney disease. Similarly, in the other cohort, the Aurora cohort, this was a clinical trial where people are pretty well sort of evaluated before they enter a study. So we'll have to see what's the diagnostic yield going to be in this category of patients in national registries. So I imagine there's going to be a whole bunch of people who actually have a diagnosis that could be recognized if somebody looks at their clinical records more carefully. But for sure, this is going to be an opportunity to find the underlying cause of disease in a large number of people who have CKD of unknown cause.
Bien, vamos a darle la última pregunta. Sí. Ah, está bien. La última doctora, adelante.
Very nice presentation. I really enjoy it. I would like to know, as you know, the initial CHINO-Y study were not really, encouraging. So my question is, how much, how many samples do you think that we need to have for each study for representing the diversity that is going to provide critical information about real traits that are going to be significant and can be validated in pathway associated with disease?
You mean for new gene discovery?
Yes.
So I think that we have a study that's coming out that's looking at this. So I think the question is so just to make a distinction, here we looked at known genetic disorders. Okay, so we use clinically validated guidelines for diagnosis of known genetic disorders, sort of like doing a pathology review and making a clinical diagnosis. So the question you're asking is, can you find new genes? And based on this type of analysis. And we looked at the same cohort, trying to see if we can find new genes. And based on our analysis, we probably need to, a sample size of maybe 2 to 3 times larger to be able to detect novel genes. But the reality is that this is a hodgepodge of patients. This is a highly heterogeneous group. We have, this is not, this is diabetic nephropathy, hypertensive nephropathy. They all have different etiologies. So, we call them CKD, but from a pathophysiology standpoint, they're different. So we're also doing studies where we're looking at IgA nephropathy and FSGS at clinically validated subtypes to be able to see if we can find new genes. But very likely, the experience for complex diseases, for example, for diabetes, is that until they got the sample size of about 30,000, then they were not able to find new genes for those diseases.
Bueno, lamentablemente no tenemos más tiempo. Sí, adelante. Adelante, doctor.
Thank you very much for a very inspiring talk. I want to double back on something you alluded to, general internist looking at patients saying CKD of unknown etiology versus a nephrologist looking at it. I want to emphasize that the same holds true for pathologists. Very many pathologists who sign up kidney biopsies are not specialty trained, see a small number of cases, and you alluded to your patient with, quote, FSGS being reviewed at Columbia, where you had world-class pathologists, and they said this is not primary FSGS. And reading the papers with linkage of COL4 to FSGS, and the headline of the papers and the abstract of the papers say, COL4 is a major cause of FSGS. And then in the discussion, you will see a half sentence that said, upon careful examination of electron microscopy, GBM alterations were found. And it makes me frustrated because the careful assessment by a nephrologist and by a specialty trained renal pathologist should come together. And your exome studies are very valuable, but many of these cases could be detected if they were looked at carefully on the front end. You wouldn't dream in cancer about having somebody say lung cancer, would you? I mean, you would laugh. You would want to know specifically, is it adenocarcinoma, is it squamous carcinoma, is it ALK positive, EGFR positive, which ERK positive, which are the mutations, what is it? You want all of this information. And I think we should not expect anything less. So I think it's really important that all parts of the diagnostic team, including integrating the genetics, work more carefully. And just look at what you did. Your patient, you didn't just look at the report and read FSGS, I know what it is. You had it reviewed by somebody expert, and you added the genetic information. So I'm making a passionate plea that renal biopsy, what is written in a renal biopsy report, if it's not done by a specialist, it may not be as complete as it could be. Just like if you have a referral by a general family practitioner, they may not pick up on the nuances that you pick up on clinical kidney disease. And I would like your comment on my very long comment.
Okay, well, I can only agree with you that nothing beats having a great renal pathologist as your best friend. So I think if you don't have a best friend as a renal pathologist, then you should go find one. So there's tremendous value, and so I think the only additional point I would make is that in many places of the world, I've just heard that there's a scarcity of resources, and sometimes, for example, EM is not available, so that can't be evaluated. Sometimes great pathologists are not available, and sometimes patients just present too late, where a biopsy is not possible. And so this is an alternative tool that we will have that will help guide us moving forward.
Bien, tenemos que cerrar. Exactamente.